All right, welcome back to the last video of pulmonary diseases, and today we're going to be talking about asthma. Now, a lot of us have probably heard of asthma. Maybe some of you have it because it is quite a common condition. Overall, it affects about 300 million people worldwide and about 8 to 10% of the US population. So it's quite widespread. But severity level is different. So, for a general overview, asthma is a chronic respiratory disease characterized by airway inflammation and hyperresponsive bronchoconstriction. So, there is no cure for asthma. However, it can be controlled with daily medication and by avoiding anything that triggers it. Now, common symptoms for people are wheezing from peripheral airways, having a cough, chest tightness, shortness of breath, and excess sputum production sometimes. The book added that, not me. Sputum, it's just something that comes from the lungs that can be coughed out, some type of a mucus. So sometimes that also happens. Now, here's a helpful table from the textbook that talks about the phenotypes of asthma because there's different types. So we've got eosinophilic, which is the most common. About half of people with asthma have this. Neutrophilic, 20 to 40% of the population. And then there's a special group right here, exercise-induced bronchospasm without apparent asthma. So it doesn't look like they have asthma, but they're having kind of like an asthmatic reaction to exercise. So yeah, it happens, especially in elite athletic populations, which is very interesting. Now, I won't go over every single point here for the sake of time, but there are differences in the different phenotypes based on their pathophysiological mechanisms. So, for eosinophilic, for example, there's a thickening of basement membrane, and it's responsive to inhaled corticosteroids, so that's a good treatment medication. Um, and then neutrophilic, interestingly enough, it's often severe. So if someone has it, it's often severe and it's associated with environmental irritants. So maybe different types of chemicals in the air, stuff like that. There's no thickening of the basement membrane. And inhaled corticosteroids do not work for them. And then for that group that um yeah, just has it for exercise, essentially. It's exacerbated by the presence of environmental irritants, and it gets triggered by different things like thermal and osmotic stress. Um, and some of that also occurs in the eosinophilic and neutrophilic groups. So a little bit more about the basic pathophysiology. So, because this is a long word, exercise-induced bronchospasm, I'll be calling it EIB from now on. So that occurs in eosinophilic and neutrophilic types. So again, here's that group, the EIB without apparent asthma. That's what it's officially called. Sometimes this also occurs to people who seem to have normal airways and don't have asthma, but have those reactions. So that's the main thing that we'll actually focus on for the exercise response. So just keep that in mind for now. Now, as far as the causes of asthma, exercise itself is typically the cause of this bronchorestriction for some people. And overall, the mechanism for why this is largely unknown, but it's most likely initiated by water loss from airway surface liquid. And that's because it causes changes in the osmolarity in the airway cells. So, in uncontrolled populations where they have asthma and it's, either they haven't been, they don't have the medication for it, they don't know how to control it, they don't know what the triggers are. These people risk severe exacerbation, potential hospital admission, and at the worst case, death from exercise. Now, that sounds serious, but I mean, it is, right? However, if it is controlled, then people can exercise normally, they can achieve the typical benefits associated with exercise, and they can compete at the elite level. So clearly, the main thing with asthma is going to be, hint, hint, seeing what those triggers are, finding out how to control it, whether it's medication or avoiding whatever else it may be, and yeah, just going about your day. So it's a different type of chronic condition that we're talking about compared to the other ones, right? Now, how to manage it? There's a basic overview here. But as you saw with the different phenotypes, it will differ person to person. So first, you need a proper diagnosis. So what's causing it? Is it primarily exercise or is it other things? Um, so to this next point, prevention of exposure to irritants, it could be that it's just certain chemicals in the air or certain things that cause the asthma. So allergy testing is actually recommended here so that things like, I don't know, human dander, cat dander, all that stuff can be identified. Because if it's that, then they'll just have to avoid that to not um, to not cause the onset of asthma. Um, Also recommended to do a bronchial challenge test before exercise just to see, what the severity level is. Also, a high intensity interval warm up is recommended for this group. And then something like a face mask during exercise in cold environments, and I'll touch on that in a second. And then the appropriate use of medications. So again, recall the different phenotypes. For some, certain types of medication are responsive and some are resistant. So what are the effects on the exercise response? So EIB during exercise causes air to be trapped and reduces the partial pressure of oxygen, causing a reduction in VO2. So post-exercise, bronchoconstrictive with decrease in tidal volume. Now, overall, what this means is it just limits their exercise capacity and oxygen uptake. So steady state submax exercise causes a decline in airway function after the first 6 minutes, which is really interesting. And then high intensity activity provokes EIB, especially in cold and or dry conditions. Now, an interesting insert here from the book that I'd actually like to, kind of read from it, because I thought it was really interesting. So high intensity exercise may provoke EIB, especially when it's in an unfavorable environment. So things like, as we say here, cold or dry air, but it also could be, where airborne irritant particles are present. So increased airway responsiveness, airway mucosal membrane damage, increased airway inflammation, and increased thickening of the basement membrane in elite Nordic skiers without asthma have been attributed to long duration, high intensity exercise in cold, dry air. And then on another spectrum, the high prevalence of asthma in competitive swimmers has been attributed to the inhalation of chlorine byproducts at swimming pools. And then also for ice rink athletes, it's attributed to the inhalation of ultrafine particles from ice resurfacing machines. So that kind of can give you a little bit of an overview of what may be causing it. And again, this happens for people who also apparently don't have asthma, right? So some type of particular irritation, the cold environment and being out there for a long time. So it really depends on you, whether you're the coach or, the physical therapist, whoever you may be for these people, is to figure out, um, I guess, their exercise environment and ways to, control this, whether, yeah, it is wearing a mask when you're outside or whether it's um, finding medication that helps if something like a mask is not possible, for like swimming, right? Um, so I thought that was pretty interesting and thought you guys would like to know. Now let's talk about some medications. So I'm not going to go through all of these, but just note that like different types of medication, depending on whether that phenotype of asthma responds to it or not, will change their um like the way that they breathe, how it helps them counteract the effects of asthma, and of course how it affects exercise, right? Now some of these we have seen before. Some of them we have not. I highly recommend you just kind of look at this, maybe just save it if you do work with athletes with asthma. Um, and yeah, just know what they take before you work with them. And yeah, I will not go through these individually. Okay, so what are some effects of exercise training? Regular training can reduce the EIB episodes that people may have, and it can increase the intensity at which EIB occurs. Now, this is mainly because there's an improvement in ventilatory thresholds. I'll change that little typo. Um, If ventilatory threshold is higher, then of course, if they keep at the same intensity as when they started, they shouldn't have any issues, right? That's just some basic benefits of exercise training. But also for asthma specifically, it can decrease the need for medications and cause improvements in post-exercise lung function. So there are a lot of benefits specifically for asthma. So some recommendations to consider when it comes to testing or just working with people with asthma. A bronchial challenge test is recommended before any type of exercise programming, so you can use that kind of as a baseline to see how severe the condition is. And then understanding the severity of the disease and the level of control is also important. So again, I really do recommend, have that table of the different drugs that they use because I mean, it's all in one place and you can refer to it. And then their exercise response for pre-acute and post should be known. Also, depending on what type of exercise they're doing, so there's differences if they're doing some type of interval training or if they're doing, just high intensity, something like HIIT. So definitely know that before working with them. And then a warm-up consisting of interval type exercise may attenuate the EIB response, and choice of activity and location is important. So again, whether it's cold, dry environments like here in Bozeman, um, or location, like if they're swimmers or if they play hockey or do something in an ice rink, that's also important to know. Now, here are some factors that confound exercise testing in asthma. So, we talked about how important it is. There are things that will impact it. So, if they have asthma medication, they should take this is a funny way to say it, a medication holiday before the test. I don't think I've seen the term medication holiday before, but yeah, remove it because the point of the test is to see how they're doing without that medication. Um, and then beta blockers, we've talked about beta blockers a lot this semester, but they can block adrenergic impulses that cause bronchodilation and result in increased bronchoconstriction. Caffeine decreases the response to indirect challenge tests. And then if they've done an activity before the challenge test, the exercise before that may attenuate the response, and even a brisk walk through the testing center parking lot may affect test results. Also, a long warm shower may open airways and lead to larger than typical resting lung function. So, I'm not sure what you want to recommend to people regarding that. Like, don't take a long warm shower. I'm not sure, but this is just something to know before the test, things to consider. Also, an upper respiratory infection should not be performed for a patient who has that. So don't do a test if they have it. 3 to 6 weeks should pass um, after a upper respiratory infection before testing. And then comorbidities. So exercise-induced bronchospasm can occur with or without the above-mentioned mimics of exercise-induced bronchospasms or EIBs, and thus present a challenge to diagnostic interpretation. So those are just some things to keep in mind, some things that can be controlled, some that can't. Now, what are the recommendations for exercise programming? Well, as we mentioned, when it's well controlled, then asthma is not the chronic condition to base their exercise programming off of. So you should refer to their other conditions. So if they have other conditions, look at that. And we've probably covered it at this rate because we're pretty far along in the semester. Now, if asthma is the main chronic condition, then ACSM guidelines are perfect for them. But there is something to note. Many patients will already be active and in sports. They may not need an exercise prescription at all. And here's a quick note that there are many elite and Olympic athletes that compete with asthma. So, asthma does not limit anyone. It's not a contraindication to exercise. Rather, it's controlling it, and that's the main point with your patients with asthma. So hopefully this has helped. Hopefully now you feel more confident working with them and just again making sure that it's well controlled and you have a documentation of, what the triggers are, what medication they're taking, what environment they typically work out in. And yeah, other than that, um, that was the pulmonary chronic condition section for this chapter. Next time we're gonna move on from this topic and we'll kind of move into different ones that we haven't really talked about. So it'll be a lot of um, kind of unrelated topics stringed together. As we bring the semester to a close, we only have a few more weeks. So I will see you then next week.